Breast cancer treatment doesn't just end with the removal of the tumor.
For many patients, the real challenge begins with rebuilding body image, self-confidence, and quality of life after treatment. At this point, reconstructive plastic surgery becomes not just an aesthetic intervention, but a vital part of psychological, social, and functional recovery. On the other hand, breast surgery isn't limited to post-disease repair processes. Today, aesthetic breast implant surgeries are among the modern and frequently preferred procedures planned by considering personal expectations, anatomical structure, and lifestyle. To correct patient selection, appropriate implant type, and surgical technique, both a natural look and long-term patient satisfaction can be achieved. In this episode, we'll be talking about breast surgeries. My guest is a plastic surgery specialist with extensive experience in this field, Dr. Harun Simsek. With him, we'll soon evaluate in detail surgical techniques, patient selection criteria, and how current technologies are changing reconstructive outcomes. If you want to access accurate information in this field, be sure to watch the rest of the program. Also, please don't forget to subscribe to our channel and like our content. I'm Urology Specialist Surgeon Dr. Niyazi Umut Ozdemir. If you're ready, we're starting. Harun, welcome.
Hello, glad to be here.
I believe you've come here straight from a surgical operation. Thanks for coming.
Yes, we had some local procedures at the clinic today. We had surgeries, we took care of those. Then I came here with pleasure and excitement.
I'd like to thank you in advance for taking the time. I'm sure this will be a broadcast that our patients and clients will benefit from greatly.
And I thank you for your invitation.
Now, today we'll talk about breasts, we'll talk about breast surgeries. But of course, before we get to that, because your branch has a long name, plastic, reconstructive, and aesthetic surgery.
Yes.
And as far as I know, it's one of the most difficult fields, surgical fields, and branches of medicine. You have very arduous surgeries, very long-lasting surgeries like severe burns, traffic accidents, and some very long microsurgical operations. It's actually a very, very heavy and difficult branch. There's a reconstruction part to it, and of course, an aesthetic part. Starting from this distinction to inform our listeners, what is reconstructive surgery and what is aesthetic surgery? Let's start there.
As you mentioned, it's truly a long and broad department, just like its name, because it deals with all areas of the body. And since it's about the skin, it's a department that works with all branches and performs surgeries on every part of the body. Now, what is reconstructive surgery? What is aesthetic surgery? Reconstructive surgery is a field that deals with everything from birth defects to deformities caused by accidents and body deformities resulting from skin cancer.
Where tissue integrity is compromised.
In cases where body integrity is compromised, it's about repairing and restructuring these areas, usually by using the person's own body. We are performing tissue transplants using tissue from within the patient's own body. Recently, we have achieved several important firsts in Turkey in this field, such as face transplants and arm transplants, and the world's very first cadaveric uterus transplant, which was a groundbreaking achievement in the field of medicine, where we've also performed complex tissue transfers from other donors as well.
Since you're very accustomed to microsurgery techniques in your branch,
of course, a vast majority of these surgeries are performed using microsurgery. When moving tissue from one place to another, we take it with its blood vessels, and sometimes even with its nerves. In its new location, we suture it to the local vessels using microsurgery to ensure the tissue survives.
In urology, 2 or 3 hours is a long time, but for you, 2 or 3 hour operations are probably considered short.
It's our routine. 5 or 6 hours is normal.
Reasonable, like normal.
Sure, in those microsurgeries, we often exceed that time, but for patient safety, we try not to exceed 6 hours in aesthetic surgeries, to be honest.
Longer duration means higher risk?
Well, of course, other side risks increase in that case. Since our primary goal is for the patient to enter and leave surgery safely, I generally try not to perform surgeries longer than 6 hours in my own practice. We plan accordingly. We decide on the combinations based on that.
And as far as I know, you were part of the team that performed Turkey's first face transplant.
It was a pleasure to work with Professor Omer.
Proud achievement for Omer.
Thank you.
It's one of the very significant successes he brought to our country.
Yes, I had the chance to be on the team for the first face, arm, and uterus transplants. I believe it contributed greatly to my professional career.
Yes, of course, aesthetic surgery is somewhat elective.
Aesthetic surgery is like this. It consists of surgeries for people unhappy with their physique, where corrections are made if possible under reasonable conditions. Reconstructive surgery, as you said, is generally what must be done out of necessity. Aesthetic surgery, on the other hand, is performed at the patient's request, provided the doctor also deems it appropriate.
Of course, reconstructive surgery, as the name implies, means you're reconstructing, rebuilding. The goal isn't to achieve perfection, I suppose, right?
No, while fully preserving body integrity, we also try to maintain that bodily order aesthetically as much as possible. But of course, ahead, when we perform a tissue transplant after removing a tumor in neck cancer,
Empty space.
of course, aesthetic expectations, they need to be kept low. But for instance, when doing breast reconstruction, we'll talk more about that later anyway. We try to get as close as possible to those aesthetic standards. I mean, as much as possible, of course.
As much as the body structure allows, or as much as the health status permits.
Sure.
Well, of course, in surgical operations performed for aesthetic purposes, organs also have functions. They have their roles.
Of course.
So is the goal just an aesthetic look, in quotes, a look that the patient likes? Or is it also necessary to consider this functionality and these functions surely?
Of course, it is necessary. Actually, here it affects people both in terms of appearance, function, and psychologically. So you need to keep all of these together. How can I give an example? Let's say a patient with very large breasts. In her life, she might struggle to tie her shoes. She can't exercise comfortably or wear clothes easily. I'm trying to explain it in terms of life functions. And when her breasts are reduced, it actually affects her entire lifestyle.
Maybe back pain, right? Her back pain decreases.
It decreases a lot. She can exercise with ease. She feels much more active and better. This actually provides a holistic improvement. So the surgeries we do aren't just things that fix the appearance. They are surgeries that affect the patient's quality of life and their psychology. That's why you shouldn't look at it like that. Now, of course, with social media becoming so prominent, these surgeries are being oversimplified. They can be done in an exaggerated way and so on. But actually what we're trying to do here is to do what the patient needs and both increase their quality of life and psychological while improving their conditions, also to fix their appearance.
Plus being able to preserve the organ's future functions, I suppose. For example, you did a nose job. It turned out great, but
breathing,
they can't breathe.
Of course, that can't happen. I mean, of course, exactly. Success there is achieved with a nose that can both breathe well and has a beautiful shape and looks natural. Do you see what I mean? Or in breast surgery, it needs to be done at a level that looks good, fits the patient's body, and allows them to move comfortably.
It's necessary. You've been performing surgical operations for a long time, of course. It's been years and years. Over these years, over these decades, plastic surgery and reconstructive surgery have undergone a transformation as well, I think. I mean, we used to hear about these surgeries less during our own residency. Certain aesthetic surgeries, now I think it's much more common. Well, maybe the demand among men was lower.
Started increasing for them.
Of
course.
Has demand for plastic surgery changed?
There's definitely a transformation like this. Actually, of course, it's developing and evolving within itself. For example, in the 90s, changes were made with much more catastrophic, heavy, major surgeries. Now, we try to achieve results with much smaller interventions, meaning less damage and more results. In addition to this, non-surgical procedures have also started to increase significantly. We are trying to replace surgical procedures with non-surgical ones, essentially preventing tissue deterioration before it happens. Actually, I'm mostly talking about the face.
Methods we call more micro-invasive.
Of course, exactly. Other than that, in body surgeries, of course, techniques are evolving and devices are coming into play. Especially after surgery, skin tightening devices have very actively entered our lives to correct the formations in the skin. These cause both the nature of surgeries to change and the demand to increase. It's definitely in a state of change. Men, of course, have also started to show a very serious demand now. In men, the most demand is actually for the gynecomastia problem, breast enlargement, which starts in adolescence, as you know. This is still one of the surgeries we perform most on men. Along with this, liposuction is generally very common because a patient coming for the breast area usually has significant fat in the abdomen and waist as well. To correct this as a whole, liposuction is among the surgeries that are highly requested and that we perform.
I guess tissue sagging can also occur as a result of obesity surgeries, right?
Yes, of course, it's the same for men. As the number of obesity surgeries increases.
Removing those skin
Excesses, exactly. Removing them too. One of the procedures we do most. Besides that, they've started to give a lot of importance to the face area now. So frankly, there's a lot of demand for eyelid surgeries, facelifts, and rejuvenation procedures.
Yes, people's professional lives no longer end in their 40s like they used to. They want to be more presentable, they want to look younger and more dynamic. Therefore, those facial surgeries, both in my close circle and among my patients, there are really many who have them done.
A lot.
There are. Maybe it's a necessity brought by professional life.
Well, as we mentioned at the beginning of our conversation, these kinds of procedures are actually ones that mentally boost people's self-confidence and make them feel good. So we shouldn't look at it from that perspective. Like someone getting plastic surgery is doing something bad. Or, for men, it's often seen as something else. It's not, of course. I mean, the important thing there is to do what makes you feel good. And here, of course, it progresses with the right procedures done by skilled hands without spoiling that masculine structure.
And of course, boundaries are certainly important.
They need to be set. Now, everyone has jumped into this field, I mean, regardless of their specialty, everyone is unfortunately chasing after performing aesthetic procedures.
And we see the negative results
quite often. I mean, things done very unconsciously, even if not malicious, because the competence isn't there. Now, we all grow up coming from a certain training, so the perspective of a plastic surgeon and another specialty cannot be the same. That's why even without bad intentions, people can't get the same result. Then correcting those becomes much more difficult.
Well, that's actually a question I'm very curious about. I mean, of course, proper patient selection is the most important thing for us surgeons to learn.
Exactly.
Perhaps something we learn over the years. Operating on the right patient at the right time.
And every time thinking I've learned it well, only to
still
get caught out.
It's an area like that. Perhaps this is the most important issue in surgery, the right patient. But then, of course, especially in your field, there's also the patient's request. They have an expectation. Now, there's demand on one hand. Of course, there's a group of patients who aren't happy with many parts of their body, what we might call body dysmorphic disorder, who won't be happy no matter what you do.
A patient
group. So how do we make this distinction? Now, of course, health also comes into play here. I mean, there might be some requests that shouldn't be fulfilled.
Sure.
Happens.
Quite a lot. Well, from my perspective, I actually proceed like this. Now, I have my own set of boundaries. There are things that can be done and results that can be achieved. There's an ongoing process between the patient entering and leaving surgery. Now, no matter what, you can't just take anything and turn it into the result you want. A change occurs only to the extent that the patient's body allows. Now, in our consultation with the patient, we first try to explain these things. We try to explain the possible results we can achieve in very clear language. And from the surgeries we've done before, we show the results we can get on patients with similar bodies, the scars that will remain, and what kind of result it turns into
after a year,
and so on. We show it all. Based on the patient's reactions here, we form an impression. Do you know what I mean? The answers they give to what I say, their facial expressions, like their expressions of liking or disliking when I show the results. It's completely
an emotional transfer, actually.
Absolutely. In this pre-op meeting, we don't just discuss the surgery, decide and leave. I'm trying to get to know the patient. I'm trying to understand if they're suitable for surgery. The patient is also trying to get to know me.
How realistic is their expectation?
That's really it. So if the patient gives me the vibe that they'll truly be happy with the result of the surgery, we proceed. If their expectations are too high, they won't be happy with the results I show or explain, and they'll realize it won't happen. And some of them really don't know much. I mean, what's possible? Actually, a very high expectation. Or, for example, maybe it happens to you too. Like, for instance, she's 50 years old, but she comes with a photo of a 20-year-old. She says, I want breasts like this.
She wants this.
Now we explain, look, you're 50 years old. You've given birth twice. This person is only 20. There's no way your body can look like this. There are those who say, oh, yes, right, and move on. Sometimes there are those who accept it reasonably but can't achieve it. After all, you're providing information there. So basically, in that consultation, after a while, you try to understand things. But as you said, this is something we can only understand over time as we gain experience.
So we don't try to meet
every
expectation.
Never. Never. I have my own principles. If the patient aligns with these principles, we proceed. If their expectation is outside of this, I can comfortably say, I'm not the right doctor for you, look elsewhere.
And of course, I'm sure you encounter some requests that push the limits of the body.
Absolutely, there are many. But something like this also happens now. It's the 9th year of my practice. Before that, I had a 3-year hospital period. Now, as time passes, people actually start to get to know us. Patients start coming accordingly. I mean, for example, they might not come at all, saying, Dr. Harun won't do this anyway.
They get eliminated over time.
Of course, I mean, it works like this. You treat a patient. The relative sees you, hears about you, and after a while, people start to understand the kind of work you do. Patients start coming accordingly. This reduces the need to do that elimination yourself after a while. I mean, suitable patients start coming anyway.
So that professional discipline actually shapes that patient portfolio after a while.
Exactly. I mean, the patient says this, I want, say, a 600cc or 800cc implant. They say, Dr. Harun won't do this anyway. Do you see what I mean?
Great. I mean, medicine is actually like this.
Yes.
It's something nurtured and grows. You don't become a specialist doctor in a day. It takes 10 years.
It takes years, definitely.
Now let's open the topic of breasts. Our main topic today is breast aesthetics
And
reconstruction in breast cancers. Now, breast tissue is very special, of course. Compared to all other body organs, it certainly has a psychological meaning for women. A symbol of femininity, or rather a symbol of the feminine image. Therefore, interventions made there can actually open deep wounds in a woman's soul. It can also take things to very different positive levels. In that respect, it differs from other organ structures. Of course, with your years of experience, you already observe this in your own patients as well. Of course, there's also the reality of breast cancer,
which
is the most common type of cancer in women and one of the types of cancer that requires surgery the most, and it's still the first option as far as I know, which we'll discuss with Ali Özlük. The operation will be it will be necessary somehow during this process.
It's needed in all of them, as in everything, to certain degrees, exactly.
Now here, I guess reconstruction is needed before or after breast cancer surgeries.
Well,
when do we do it? How do we do it? And how do we decide?
Well, as you said, the breast is one of the most important organs for a woman. We might not compare it functionally to an arm, a hand, or a leg. But the breast, coming from thousands of years ago, has something it gives to women or to life.
So it's a very universal thing.
If you look at statues from the Hellenistic period, the breast always represents life, an organ that sustains life, symbolizing giving life and vitality. First, it's a feature of women's health that distinguishes them from men. Second, she has a baby. She breastfeeds it, nourishes it, and forms an incredible bond. And so on, its value is truly indisputable. We'll get to breast cancer, of course, but it's like this. In aesthetic surgeries related to the breast, it's also like this. The breast doesn't necessarily have to be removed. Let's say a woman goes through pregnancy once, twice, or 3 times. She breastfeeds, gains weight, and then loses it. Suddenly, that organ she cares about so much ends up in a very bad state. The breast doesn't necessarily have to be removed. Its correction is necessary under all circumstances.
Sometimes it's needed.
In order for her to feel good about herself again, if it's deteriorated, of course, and if she's bothered by it. In breast cancer, it's like this. In all cases of breast cancer, surgical intervention is required anyway. Depending on the size, location, and number of masses, only the area with the mass can be removed. The breast can be emptied while preserving the skin, or if there's skin involvement, everything can be removed together if necessary.
There are many factors here, like the tumor's stage, type, and prevalence. Maybe the patient's age, right?
Of course. What do we do? Actually, we can get involved in all of them as plastic surgeons. For instance, even if only the area where the mess will be taken is removed, when that area remains empty, deformity can occur in the breast during the subsequent healing period. In patients where we can preserve the breast skin, we operate in the same surgery. We can prevent breast loss in the same surgery using silicone prostheses or the patient's own tissues.
So simultaneous operations can be performed.
If the entire breast is to be removed, it can turn into delayed reconstructive surgery performed later. But currently, I'd say the rate of patients whose skin we can preserve is 90%.
Those are quite high rates.
And I work together with Ali Ozluk. You know Ali Abi closely as well. We do almost half of his patient group together. So reconstruction has actually increased this much.
Is it also linked to the increase in early stage diagnoses?
Both that and the current state of surgery has also changed. Such aggressive surgeries are no longer being performed. In the end, there's no difference between total mastectomy and skin-sparing surgery for suitable patients.
The technique evolved.
The technique has evolved. Well, the surgeries performed also demonstrate this. The studies also demonstrate this. So if it's possible to resolve this while preserving the skin, that's the path taken, because there are significant differences in the treatment process between a patient who lost a breast and one whose breast we could save. I mean, facing that loss of an organ or not facing it, there are two options. This clearly affects the patient's subsequent treatment process.
It affects it.
Exactly.
Of course, we also have patients who underwent radiotherapy and chemotherapy.
Sure.
Certainly after surgery.
This happens too.
How does this go?
Now, this is one of the areas that most affects breast reconstruction or other reconstructive surgeries if they're oncology related. They've already received chemotherapy beforehand. They've had 8 cycles, 12 cycles of chemotherapy.
Sometimes before the surgery, right?
Yes. If the mass is very large or if there's involvement in the armpit, etc., they receive chemotherapy beforehand, or even if they're going to receive it afterwards. I mean, we're operating on a patient who has received or will receive chemotherapy. We're operating on a patient who will receive radiation to that area. And we try to come out of it with minimal problems and in the best way possible. That's where the difficulty of this work comes from. When I explain it to my patients, I always say that this work is really, a much more laborious and difficult process than aesthetic surgery. But I will take this risk, and you will take this risk too, because in the end, I say it's about saving an organ. And women are already very, they're strong in this regard. Managing such a field with women is different compared to men.
It's much harder. I mean, working with men is really...
Women are truly much stronger and more resilient in this regard, to be honest.
Well, of course, during reconstruction, it's probably also necessary to adjust the symmetry with the opposite breast. So one side was operated on. The implant was placed, the reconstruction was done. But how do we also ensure symmetry with the other side?
Well, actually, the new generation of silicone prostheses are much more suitable for this. As technology advances, there are methods that actually make our work easier. We couldn't actually place the classic silicone prostheses used in aesthetic surgeries directly under the skin because the breast was emptied. We had to use the muscle. And in the muscle, actually, if the breast is here, the muscle is located here. This time, the new breast was located higher up. If we weren't going to operate on the other breast, there was inevitably an imbalance, or you had to move that one here too, and so on. Now, with new generation prostheses, we can place them directly over the muscle, under the skin. And what does this provide us? Wherever the other breast begins, we can start the reconstructed breast from that same point. One of the most important points here is to preserve the natural look and the line of the cleavage. So we make sure the breast sizes match up. Of course, if we operate on one and not the other, there will inevitably be a slight difference. The patient already accepts this possibility because one is natural breast tissue while the other is a silicone prosthesis. There are always some differences, but then again, these differences always exist from the start. I mean, asymmetry is already inherent in the nature of breasts. In 90% of all women,
there is some degree of asymmetry.
Same for the face, the whole body is like that. Do you know what I mean? And that is why
the line is symmetrical.
Of course, we obviously try to get the best result for when they are undressed, but we spend 99% of our lives clothed. So we tell patients, let's aim for the best result when undressed. But the important thing is that when you are dressed, whether wearing a swimsuit or bikini, a bra or a strapless dress, you should not feel that anything is missing. That is our primary goal. The second is to get the closest possible match when undressed. Nowadays, we often perform the procedure on both sides. Patients undergo genetic testing. If the genetic test comes back positive, we operate on the other breast as well. This also provides an advantage for us in terms of when we perform the same procedure on both breasts, we achieve a more symmetrical result.
The possibility of cancer in the other breast.
Or if there will be a significant visual difference between the two breasts. I say there is no problem on this side, but to make the breasts look alike and to reduce risk, I suggest it is beneficial to operate on the other breast too. If the patient agrees, we empty both sides and perform the same procedure.
Well, if there is a deformity in the other breast, a natural one, the patient might request an intervention there too.
Of course they do, exactly. Or for example, it happens like this. One side is very saggy and large, but she says she does not want it emptied. While we empty this side and use silicone or her own tissue, we only do a reduction and lift on the other side. Again, we try to make them look more alike.
As in all areas of medicine, a personalized treatment plan must be drawn up.
Exactly. To be honest, we decide on this together during consultations with the patients.
Well, in cases where cancer has progressed, I suppose the nipple can also be lost, right?
Sure.
In that case,
we also perform nipple reconstruction.
How do we achieve this, or how do we decide?
Actually, in every surgery, a biopsy is taken from the patient's nipple during the procedure called a frozen section. As you know, a frozen section is processed. An examination is carried out during the surgery. If there is involvement in the nipple is also removed from the patients. In this situation, there are two options. One is that we perform a surgical nipple reconstruction. Here we create the tip, which we call the nipple, from the patient's own skin. If the other nipple is suitable, we can transfer skin from that brown area, or since the genital area is dark, we can perform a nipple reconstruction by transferring skin from that area. But in the late period, meaning we don't do it with the first surgery,
after all the processes
have been completed, or very nice tattooing is being done now. Three-dimensional tattooing is being done. There are patients who prefer this as well, or there are patients that I refer to it. So if they've been heavily affected by radiotherapy, or if their skin is very thin, then surgical breast reconstruction can put things at risk. I mean, it can also put the first surgery at risk. In that case, tattooing, getting a tattoo can be more sensible.
We're not without options in this regard either.
No, absolutely.
It can be done.
Absolutely.
Yes, now, of course. The cancer aspect, the organ loss aspect, the reconstruction aspect are all important, of course, but nowadays many women also request breast implants purely for aesthetic purposes. They can ask for them, they can want them. And here, of course, there are various techniques as far as I know, like over the muscle, under the muscle, interventions through the armpit,
or
interventions around the nipple, or incisions from the inframammary fold. How are these decided upon? Do we evaluate it with the patient? Or does every surgeon have their own technique?
Actually, while we act according to the patient, every surgeon can also have a technique and a preference. So, for instance, what I get the best result from by making an inframammary incision, someone else might achieve for themselves by doing it through the nipple or the armpit. So, where the incision will be made is actually chosen like this. I usually do it from the inframammary fold. The reason for this is actually the most common problem in silicone prosthesis surgeries, what we call capsular contracture, the capsule that forms around the prosthesis hardening and solidifying in the long term, causing deformity and sensory impairment there, which can only be corrected surgically. Anyway, research actually determines these things. In surgeries done through the nipple, and the armpit is already done very rarely. In surgeries done through the nipple, when the prosthesis is inserted, if bacteria in the milk ducts in the nipple come into contact with the prosthesis and enter with it, this contamination is actually one of the most important reasons for capsular contracture in the long term. Besides that, in incisions made under the nipple, reasons like the possibility of even a small loss of sensation in the nipple led plastic surgeons to prefer the inframammary fold.
The general preference is the fold.
Actually, these are matters acquired through studies and experiences over time. For example, the inframammary fold is used 90% of the time worldwide, for instance. So these are actually, for example, when I first started surgeries, I used the periareolar incision. But over time, with experience, what we read and what we saw at congresses, I switched to the inframammary fold. I've been using the inframammary fold for a long time. And I almost never encounter these problems I mentioned. These are actually a result of those scientific studies. Issues like where the breast implant will be placed, under or over the muscle. A patient's
size.
These are things we decide entirely based on the patient. And again, to either never encounter post-operative problems or to get the best result, those studies already show us what we need to do. As I said, if a patient is very thin, if her breasts are very small, we generally prefer under the muscle there because that implant needs to be covered with thick tissue somehow. and the external visibility needs to be minimized. But if the patient has some breast tissue or slight sagging, the muscle stays up, and since the breast will be lower, we prefer over the muscle.
But what do we base decision on?
Yes, based on the patient's anatomy. Actually, I hear this a lot. Like, doctor, I heard under the muscle is better, and so on. There's a very common public belief like that. But it's not like that. Under or over the muscle doesn't really have an advantage over the other. Whichever is suitable for the right patient is the best one.
In terms of appearance,
Absolutely
no diff.
none. So we decide entirely based on the patient's anatomy. Exactly.
And for the size, I guess, with the patient,
For the size, we do this. The breasts,
a consensus needs to be reached.
of course. And there's no such thing as, we can put any size we want on any body or any breast. The breast diameter, skin laxity, and the width of the patient's rib cage, all of these give us a direction. There are also many mathematical calculations regarding these. So we have implant sizes that we try out before the surgery. In pre-op consultations, we first calculate what the largest and smallest implants that can be placed in this breast are. In those ranges, let's say an implant between 250 and 350 can be used. Then by trying out these implants,
according to the
patient's wish,
by trying them externally,
of course, we have them wear a bra, a special bra. By placing those sizers inside it,
it's like this.
Yes, the patient wears it, puts her clothes on, and looks. There are also digital tools for this.
3-dimensional
platforms as well. I used them once too, but I think the most realistic way, in my opinion and preference, though different doctors may have different views, I think we make the best choice by putting them in a bra and deciding in front of the mirror. Because even when I project that implant onto the person's breast in 3D, the patient can't see it as herself. She sees it like it's someone else's breast.
That feeling doesn't come through the screen, of course.
It doesn't. That's why my preference is usually in this direction.
Well, if it's larger than what's appropriate, could it cause other problems?
Of course, like this. Well, of course, for example, there's still a margin of tolerance there. Let's say we want to give the patient 350. The patient might want 400, or we want 250, or maybe I'm suggesting 300. The patient wants something smaller. 200, well, such small differences don't change much. But if there isn't enough space now, in a place with no space,
if there's no gap,
if not, when you put something much larger there, of course, first it raises the cleavage area significantly. The distance between the neck and breast shortens and it starts here. Second, it extends toward the armpit.
It can overflow.
Since there's no room here, it mostly shifts to the side. And this leads to a very uncomfortable and unpleasant surgical outcome for the patient.
Discomfort.
Absolutely.
It can be obvious.
Visually, when you use a large one, that prosthesis becomes much more apparent. If the patient wants a natural look, it's better not to go too big.
They should trust their doctor or listen to their advice, right?
Absolutely, but it's the opposite. In Turkey, patients are actually more afraid of going too big. At least my patient group is. I'm the one trying to convince them. They say, oh, I don't want it too big. They don't want to look unnatural or anything like that. I try to persuade them otherwise. Look, if you choose this, I think we should go one size up. Because many patients later wish they had chosen a larger size.
Well, looking at some plastic surgeons' portfolios, there are some exaggerated implants. I guess the demand finds them.
Yes, well, they are working.
They find them, I guess.
Now, their patient group, as I mentioned, every doctor has a style and preference. Patients come based on that. So, for example, from abroad, a patient group like dancers or actresses might request different things. But let's say for those with more normal living standards, the patient group makes choices accordingly.
Well, before performing these surgeries, we need to do some tests and imaging, right?
Of course.
Is it based on age or family history? Which tests should be done and are necessary?
Typically, regardless of age, I always recommend preoperative breast imaging for these surgeries. Because we've had many breast cancer patients even in their 20s. So I no longer think this patient is only 23 or 25. I shouldn't ask for this.
Breast cancer isn't like prostate cancer. It's not just for older ages.
It's not.
It can be encountered at a very young age too.
Exactly. We've seen it a lot, even under the age of 30. Therefore, I require pre-op imaging for every patient, like a breast ultrasound or mammography. Maybe there's a distinction there. I mean, if the patient is, say, in their 20s or early 30s, an ultrasound is usually sufficient. If they're over 40 and the breast structure is suitable, we evaluate with both ultrasound and mammography.
Yes, we evaluate it. And if there's a possibility of bladder, breast cancer, of course, we don't perform this operation right away.
We don't perform it. In fact, there have even been patients diagnosed with breast cancer during this process. They applied for aesthetic surgery without having any idea. And then, following our recommendation, they had a breast ultrasound, a mass was detected, and they were diagnosed early. That's why I think it's very important.
Then the type of surgery, of course,
changes. First, they receive treatment for that, and so on. After that, of course,
the process can proceed differently. Okay, so we've performed this surgery, everything is going well. How does the process go for people returning to social life, exercising, starting sexual activity, or resuming daily activities?
Now, the two questions we get most often during surgical consultations are, Doctor, when can we start exercising? And second, when can we start having sexual intercourse? It's a classic thing. For a while now, well, for 2 years, I've been exercising very regularly again. Before that, I used to think, everyone comes and asks this. So, doctor, when can we start exercising? I always say to myself, am I the only one in life who doesn't exercise or something? In fact, once
Like that,
I said something to a patient who didn't ask. I said, you can start your exercise in 2 months and start walking in 3 weeks. I don't exercise anyway, doctor. She said, I wanted to get up and hug her. The patient. I said, bravo, because a patient who doesn't exercise finally came along. Actually, it varies depending on the surgery. If we're talking about breast surgeries, they usually start their walks very comfortably after about 2 weeks. If they do sports like Pilates and such, I have them start leg movements and so on after 1 month. But if there are things
that will work,
the chest muscle, I try to have them wait at least 3 months.
Lifting or working the thorax.
Yes, in those cases, I actually don't recommend putting excessive strain on the chest muscle for life. I think that muscle movement there will definitely cause deformation in the long run. That specific muscle movement. Therefore, I guide them more towards things like cardio exercises, Pilates, and so on, which will help them stay fit.
Well, regarding sexual life, what's meant here is probably not sexual intercourse, I suppose. It's probably things related to the breast. What do you call it? Contact?
Well, as I said, I think we shouldn't just focus on the breast. After all, liposuction, tummy tuck, and so on. We don't just do breast surgery. Patients have this question regarding all of these procedures. Of course, if we've performed surgery near the genital area, I recommend they wait at least a month. But if we've done breast surgery, that depends on the nature of the sexual intercourse. It depends on the intensity of the sexual activity. Of course, they can do it whenever they want, as long as they protect the breast.
Don't traumatize it.
Yes, as long as the surgical site isn't traumatized, it's an open-ended topic.
So is there still a 2 to 3 month period here as well?
Well, if we've done genital area aesthetics, there is, but if we've done breast surgery, I don't think so. After a month, that area becomes easily
touchable
again.
So is the loss of sensation experienced here a natural thing? Is it something expected?
It's like this.
It passes with time, something like that.
Yes, so it's like this too. Now, there's always some loss of sensation around every incision site. In tummy tucks or facelifts, because the sensory nerves around the incision are affected, there's temporary loss of sensation. To be more precise, these usually return completely within the first 6 months. Coming to the breasts, in breast augmentation, again, there might be numbness only around the incision. But in lifts and breast reductions, since the area around the nipple is completely cut and moved upwards, as textbook knowledge, in 5 to 10%, there can be permanent loss of sensation in the nipple. And we already tell this to patients before the surgery. But in my own practice, I see it less often. There's less loss of sensation. Then permanent nipple sensation loss can occur.
Yes. Is it probably a bit different in cases where implants are inserted through the nipple?
In cases of nipple-inserted implants, this time, even if temporary, something unnecessary happens to the nipple, or even if it returns, there can be a difference between the two. So, as I said, because the nipple is a place where sensation is important for a woman, where she gets sexual pleasure, I feel it's an area that shouldn't be touched much unless we absolutely have to.
We've talked generally, but what are patients' biggest fears usually in this surgery? While deciding before the final decision, yes, they want such an operation, but they're hesitant about some things. Which fears are most often
mentioned?
to you about this?
Generally, it's like this. Patients are afraid of receiving general anesthesia. I think it's like this. If a patient wanting surgery is too relaxed, actually, I think being a bit worried, a bit more anxious, seems more suitable for human nature. Do you know what I mean? If the patient is too relaxed, too whatever, then I say, wait, something might be wrong.
Yes, yes.
Of course, if they're getting general anesthesia, they're afraid of that. They're afraid they'll suffer a lot of pain after the surgery. I think this is the question we encounter most often. And here, I think certain things come into play. The surgical technique, the hospital you use, the anesthesia they get, how they wake up from surgery, and so on.
Post-operative care.
When these are done well, the post-op period really isn't that scary. Patients hear a lot of things from those around them. I couldn't walk for months, or I couldn't lift my arm, and so on. But if these are well managed, I think the surgical process goes very smoothly. Of course, for 2 or 3 days, a week, there will definitely be sensitivity in the surgical area, but it doesn't go as they fear.
Yes, of course.
Of course, they feel anxious about the shape.
Like, will it be too big?
Will be small.
Will it be as I want? Will it be as I imagined?
Of course, if it's saggy, will it sag again, and so on? How will the scars be?
Yes, absolutely, without a doubt.
After all, there are many patients who even think there won't be any scars.
So
ultimately, if there's a cut, a scar remains. What we do here is try to achieve the best possible scar. That's what we try to explain.
This is as much about the patient's wound healing process as it is about surgical technique.
So if 50% depends on the doctor and technique, the other 50% depends on the patient's skin.
And to prevent this, I believe certain creams and such can also be used after the operation.
We generally do it like this. For every surgery patient, after 2 months, we apply 5 sessions of carbon dioxide laser at 1 month intervals. This is usually included within the surgery package. Afterwards, there are silicone tapes, silicone sheets. We recommend those. Once the wound has healed, we suggest using them for the first 6 months to a year. As you mentioned, there are gels and creams. We recommend these. If the patient actually follows these, we get a much better result than the scar that would normally occur. But again, the biggest factor is the patient's skin type. So even if we apply all of these, sometimes we can't reach the desired result. Or even if we don't do any of these. For example, the patient leaves. After the first few checkups,
they don't follow any of it.
They come back a year later. The scar is almost invisible. So the patient's skin type is absolutely crucial.
Exactly. You look at a patient you've operated on. Sometimes you have a lot of trouble even finding the scar. Exactly. Sometimes it's structural.
Sometimes the scar may stay.
Of course, it's the patient's constitution. In the same way, well, regarding these implants, it was debated a lot in the past, but I guess that debate isn't very active now. Like, could it possibly cause cancer? There were some concerns like that. Are they still there?
Well, actually, there's no risk in terms of breast cancer. So if the question is in this sense, it doesn't increase or decrease the risk of breast cancer. We already use them for patients who have breast cancer.
So
we use them for patients who are already at risk. What's actually being mentioned here is a type of lymphoma. Anaplastic large cell lymphoma is a type of lymphoma that develops from the capsule of the implant. This reached a very high point around 2016 and 2017. Even in the research conducted during that period, the number of patients didn't exceed 1,000, and 80 to 90% of these were actually linked to one specific brand. Later, that specific model of the brand was already withdrawn.
Withdrawn from production.
In other implants, they researched what it depended on, and these implants have these textures on them.
Yes.
It was mostly decided that it depended on the width of those textures. There were people who decided to continue with the smooth ones. But smooth ones increase the risk of capsular contracture by 30%, and there's more deformity. As for the textured ones, they've now switched to microtexture. Actually, it's hardly been discussed for the last 3 or 4 years. For about 2 or 3 years, at all congresses, social platforms, everywhere, it was ALCL, large cell lymphoma,
implants.
It was also added to our consent forms. But these aren't things I see in practice. Hardly ever. I honestly don't hear about it or see it anymore.
And I also see it on social media from time to time. I think there are women over a certain age who want to get rid of these implants. This can also turn into a trend from time to time. In other words, we can encounter people who say they got rid of these breast implants and feel very relieved.
Again, this is actually one of those things that gets popularized from time to time. At one point, it was really like after the implant, the whole body's balance is disrupted, functions are impaired, and so on. but I don't hear those things anymore. Quite a few people used to come and ask. I haven't heard this for a long time either. This is asked a lot, do we need to replace these and so on. Questions like that.
Do they have a certain lifespan?
This is one of the most frequently asked questions. Again, 99% of the time, you can use them as long as there's no problem.
No need.
But what can happen? Well, after 20 or 30 years, they can, of course, become deformed. Their shape can get distorted internally. Capsular contracture can develop. At that point, they can be replaced with a simple surgery, these implants. But the patient doesn't actually have to replace them.
Yes, they don't have to have them removed either.
No, but
they don't have to
replace them. Yes, but this can also happen. I mean, they get it done at age 20. Now they're 60 or 70. I've never seen 70, of course, but they reach their 60s. Either it feels too big, or they don't want to live with that weight anymore, and so on. Then they can have them removed, of course.
There are things that can be removed whenever they want.
Of course.
These are implants. Well, does it interfere with breastfeeding? Because it can also be done at young ages. As far as I know, there are those who prefer it in their 20s or maybe even earlier.
Of course, we actually perform these surgeries more at that age, in their 20s. It has no effect on breastfeeding. I mean, no negative or positive effect. Since we work entirely under the breast tissue and often under the muscle, we have no connection with the function of the breast as an organ. It has no connection. In fact, for a long time, when we say breast surgery, we don't just do silicone implant surgery. We don't. We also do a lot of breast reductions. We do a lot of lifts too. Now, that concern comes up a lot with these too. I mean, there are patients who have waited a long time just for this reason. I mean, there are patients who have reached 40 but are waiting or being made to wait because of reasons like you'll get married, have children, breastfeed, and it'll sag again. They reach 40. Sometimes they've never married or haven't had children, or even if they did, they couldn't breastfeed. They've spent 20 years carrying those large breasts for nothing. I'm definitely in favor of them getting it done and being relieved as soon as possible. I have many patients who are 18, 19, or 20 who get breast reductions because it's an open-ended issue. I mean, women don't get married at 20 anymore. Do you know what I mean? They don't have children at 22. Generally, there are few who even get married before 30 now. So there's no need to spend the best years of their lives with a huge burden on their neck and back, unable to wear the clothes they want or the bikini they want. That's why I recommend they get it done as soon as possible.
Well, is there a certain lower or upper age limit for these surgeries, perhaps ethically?
Of course, we usually wait until 18. I mean, for all kinds of aesthetic procedures,
there can be demand under 18, as I understand.
There is, for instance, with large breasts. Sometimes we have 16 or 17-year-old patients who struggle socially. But I try to wait until 18. I'm a bit more flexible with gynecomastia because gynecomastia really sets boys back during that puberty period.
Yes, absolutely.
There are prominent severe cases of gynecomastia. It's not just a little breast enlargement.
Noticeably large.
There are some that are very large. Some are very feminine in shape. Now these kids become, they become very antisocial. They don't leave the house. They won't even wear a t-shirt in summer and so on. So we don't wait until 18 for them.
They want to go to the pool or sea.
Of course, if the family approves, we certainly have patients at 14, 15, or 16.
Male breasts culturally.
It's the same with prominent ears. We perform ear pinning surgery at age 6 because by age 6, the ear has reached 90% of its full size. Now, if the child spends their whole school life
having problems and being emotionally traumatized,
then there's no point in doing it at 20.
You can't say be traumatized until 18 psychologically and then come back later.
I mean, there's no point in doing it after that much trauma. That's why we do it as a child, for example.
So in aesthetic surgeries, there's almost no age limit, but of course, depending on the surgeon's discretion.
Look, it's like this. The development of the organ involved, for instance, we tried to wait for nose surgeries because development continues until age 18 anyway. Cartilage and bone development. If you perform rhinoplasty on a 15-year-old, it might deform again over time. Do you see what I mean? They might need surgery again. That's why we recommend waiting,
Exactly, depending on the situation. What about artificial breast tissue? I mean, the tissue engineering side has started to develop as well. Are there any developments regarding this? I mean, in the future, without the need for implants, can certain tissues be produced through tissue engineering? Are there such ideas?
Not as far as I know at the moment, but rather breast prosthesis structures are being modified. They're being made increasingly more biocompatible. Methods are being developed to perform these procedures with reduced damage and with reduced trauma, but I still haven't heard of any studies on tissue engineering yet.
Yes, probably. As the implant technique itself improves, it somehow becomes cheaper. I mean, producing a tissue would surely be a project that could require millions and millions of dollars.
Of course, cost is very important as well. I mean, that affects the surgical process and its accessibility. And so, well,
Being accessible in surgery is,
accessibility shouldn't be just for the rich. Our preference is for these surgeries to be accessible to everyone who truly needs them.
yes. And another important topic. Now, sometimes women, due to fear of cancer, might have many types of cancer in their family, especially breast cancer might be very common. The person doesn't have a cancer risk yet. But despite this, I'm sure you meet women who want to have their breasts emptied or removed.
Absolutely.
What is our roadmap in this case?
Actually, just like with Angelina Jolie, it's something very well known because of her influence. She had it done, maybe you know or maybe you don't. There's a trend that started with her. In this case, it's essential to have the patient undergo genetic testing. So it's not like your mother, sister, or aunt has it, so let's do yours too. Because the surgery performed isn't breast augmentation or a breast lift. The procedure we do is exactly what's done for a patient diagnosed with breast cancer, emptying the breast and reconstructing it with an implant or their own tissue. The risks don't decrease just because there's no cancer. Surgical risks, the same risks still apply to her. What are they? I mean, ultimately, skin necrosis can occur or the implant could be lost. After all, when these surgeries are done on a cancer patient, you can take these risks because you have no other choice. But let's say you empty the breast of a patient who hasn't been diagnosed with cancer or even tested. Things went wrong and we lost the breast. Then what? This time the patient will be left without a breast for no reason.
Organ loss.
She'll experience it. That's why genetic testing is absolutely performed. If the genetic test is positive and there's a history in the family, if someone in the family has it, then it can be emptied.
If there's a familial risk, then of course there's a justification for surgery.
It means familial risk and a positive genetic test. We usually do not proceed without a positive genetic test.
But what if all of these come back negative?
Optional. No, it's not done.
Is it ethically sound to do it optionally? Can it be done?
It can be done, but we don't do it. Ultimately, because of the things I mentioned. And patients think of it like this. I mean, they think the result of the surgery is like breast augmentation. There are differences between reconstructive surgery and aesthetic breast surgeries in terms of appearance, incision site, and so on. That's why it should only be done to prevent organ loss. So when you perform reconstruction on a breast arbitrarily, you don't get a result like breast augmentation. Do you see what I mean? There can be indentations and protrusions there. The implant can be more noticeable and so on. So it's better to do it for the patient who needs it.
So both the patient and the doctor might not be very happy, of course.
They might not be. The patient's expectation is already based on that. Let's say I show reconstruction patients to a patient who comes with this request. Look, here's the incision. Normally, in breast augmentation, a small 3 centimeter incision is made here. But here we do it with a 15 centimeter incision on the breast. Since there's breast tissue when we do implant augmentation, the implant looks like this. But since there's no breast tissue here, when we show things like, look, it looks like this, she understands anyway.
When you don't justify it medically, the chance of problems arising in every patient naturally increases over time.
That's absolutely right.
I mean, it's not something a doctor wants either. Of course, we never want any of our patients to be unhappy because happy patients are what keep us motivated in our profession.
I always say it like this. Operating on a patient is, well, important, of course, but it's not the most important thing. If you're both happy when you meet that patient for a checkup 3 or 6 months later, that's when the truly rewarding part of the job reveals itself.
Exactly. We've talked a bit about gynecomastia, but let's finally get to men. Now, men have breast tissue too. In fact, men can get breast cancer as well.
Yes, that's true.
I even remember from my student days, it was 1 in 15. If there are 15 cases of breast cancer, 1 is likely in a man.
I'm not sure of the exact ratio.
That's what they'd say. I remember from the medical exam.
Me too.
Perhaps you encounter these cases from time to time, or at least you certainly come across the problem of gynecomastia frequently. In adolescence, As we just mentioned, for men, the chest is culturally a more exposed part of the body. I mean, when going to the pool or the sea, it's obviously more visible everywhere. Consequently, it's something that affects the psychology of adolescents too. Are certain tests or examinations required here as well? Because there could be a hormonal link to this.
Of course, if the patient is in puberty, still in the developmental stage, we definitely want an evaluation by a pediatric endocrinology department. If there's already a hormonal disorder or
Prolactin, endocrine.
of course, if such a disorder exists and isn't resolved first, then there's really no point in performing surgery. It will just grow back. If there's a hormonal cause, it'll happen again. First, that must be addressed and treated, and only then should the surgery be performed. In older ages, the most common cause over 40 is actually a decrease in testosterone, which is very relevant to your field. So, lifestyle and alcohol are the biggest factors in this. I mean, for men who don't exercise, consume a lot of alcohol, and don't eat healthily, what actually happens? After age 40, testosterone levels drop, estrogen increases relatively. Visually, he's male, but hormonally, he becomes more similar to a female, and that's when the breasts enlarge. The cause is clear here. Of course, we'll perform surgery, but as with every operation, I tell my patients this. The issue isn't solved by surgery alone. They also need to change their lifestyles. Do you see what I mean? For instance, we do liposuction. We can do it, but if you continue to drink alcohol every day and keep eating unhealthy junk food at the grill,
If you continue with a fatty diet,
if you continue, this surgery really won't matter. I mean, you've had it for nothing. However, if you also exercise, eat healthily, and while you might drink alcohol, you do so in moderation.
weight control.
If you maintain it, then much better results are achieved. So the biggest issue after 40 and the biggest issue with gynecomastia is this.
The disruption of the testosterone-estrogen balance. The relative increase of estrogen, that is the female hormone, actually.
Increasing. This will actually result in many men with breasts appearing around us.
Yes.
Yes. Besides, estrogen increasing to this level and so on also affects mental state.
Of course.
It also disrupts stability.
Sure.
It disrupts stability too. We also try to explain this to patients.
Yes.
I mean, it's not just about a surgical solution. There are many factors involved, from nutrition to sports and lifestyle.
Right? But here in adolescence, it can also be idiopathic, meaning even if there's no hormonal problem and they have a very fit body, this gynecomastia can be structural.
It's usually like this anyway. We refer them to pediatric endocrinology, but I mean, I've never seen a gynecomastia patient who actually had a hormonal disorder.
Yes, but it's necessary to do it as a precaution.
And it's like this. It's something where the solution is only surgical. We talked about the same thing with women, living like that for 20 years until age 40 and then having it done. I always tell them too. I mean, just get this done when it bothers you the most and be done with it.
Yes.
I mean, it's a surgery that takes about 1 to 1.5 hours.
Be quick.
Of course, I mean, sometimes I don't even hospitalize them. Sometimes they get discharged the next day. The patient returns to their normal life after 3 to 5 days anyway, and they're suddenly rid of that problem they've suffered from for years. They're free from the problem they were ashamed of, so it's best not to delay it too much.
It's also worth making this warning here. Now, some young people, especially those who overdo sports, can be inclined to use testosterone preparations a lot.
Yes.
Now, having high testosterone doesn't mean it will stay high all the time. The excess of that testosterone turns into estrogen in the body.
It turns into estrogen.
And estrogen enlarges the breast tissue. But what happens then is we might see a man who is muscular but has breasts.
Yes, we have athlete patients coming in.
Therefore, we don't recommend such things to anyone. Testosterone, yes, can be supplemented if it's medically deficient in the body. But just to build muscle, just to do bodybuilding, if we try to take testosterone externally, it has a bad impact on cardiovascular health and also on this.
The visual result is quite bad.
It can be negative. Let this be an important warning from us. Thank you very much. Nice conversation.
Went well.
With pleasure. I think we've discussed everything from A to Z.
Nice.